No, I'll switch it when you show images. All right, hi everybody. Thank you for sticking with us through this whole day. I'm going to throw a plug in. I know Dr. Tandon is a superstar, and you might want to run out of the door after he's done, but we are going to have a great session right after. It's just going to be a 30-minute session on what's new in epilepsy. And the Epilepsy Foundation has a mobile app that's coming out in May, and so we want you to stick around and hear about it. And an incentive for doing that is that we're going to do a $100 gift card drawing at the end of our session. So please stay and hear about that. But without any further ado, Dr. Nitin Tandon from UT Health and Memorial Hermann is here. He is a neurosurgeon. We have so many families that come to the Epilepsy Foundation and are just so happy with the results that Dr. Tandon has gotten for them. And so we're so happy to have him here and talking about surgical options for epilepsy.
Thank you so much. Thanks for having me. Thank you all for being here. Sure, it's been a long morning for most of you. I generally try to speak quite fast, so if any time there's a point you want me to elaborate or slow down or repeat, please make me do that. My charge was today that I was given was to talk about epilepsy surgery in general, and I thought I would talk more generally about how epilepsy surgery as a field is evolving, not just what we do, but what we are trying to do that is cutting edge today, and then innovations for tomorrow. My talk will follow a pattern of first establishing why we should have epilepsy surgery, then talk about 10 separate patients who've had epilepsy surgery of different types, and this evolution of the types of surgery that we do will be obvious in that. I've only been here in Houston for 13 years, so it seems weird for me to talk about evolution, but I think it's a testament to how quickly things are changing, and perhaps also contributions from our much enhanced understanding of the brain. So it's important to realize that epilepsy is a very prevalent disease. It affects 1% of all Americans, and the lifetime risk of a seizure in anybody is quite high. Most people would say between 3 and 5%. So about 3.5 million or 3.5 million Americans will have epilepsy, and about 30% of that is refractory epilepsy. Refractory epilepsy is patients whose epilepsy continues despite medications, and generally those are the patients that require epilepsy surgery. Occasionally patients cannot tolerate medications even though they are controlled on medications, and that's the second group of patients who want epilepsy surgery. But the vast majority of patients are these patients with refractory epilepsy. So if you do the math, and I guess I'm in the middle somehow. Maybe I should sit down. Is that okay? Can I sit down? Yeah. Then people can see around me. So if you do the math, approximately 1% of the population times all of these numbers, you end up with about 225,000 people who should have epilepsy surgery pretty much on an annual basis. And the reality is that we have about 3,000 patients having epilepsy surgery a year. So there's an enormous mismatch. And this is despite, of course, we know that epilepsy surgery is very necessary in many cases. So this is a demonstration of what happens with drug therapy. If you start people on drugs and drugs work, that's wonderful. Okay? But that's true with one drug in only about half the population, 47%. You add a second drug, it goes up by another 13%. So by the time you fail, you've been on 2 drugs, 60% of people will be controlled. But after that, the numbers drop off very dramatically. And as you can see in kind of the staircase design, by the time the third drug has come on, less than 1% efficacy occurs. And if you add drugs and have patients on more than one drug, that does not really add that much. And so it's very clear from this, and these numbers have not changed since 2002 when this paper came out, even though the drugs that have come out are new. There is a honeymoon period with some of those drugs of 6 months, 9 months. Many patients notice that. But at the end of the day, the numbers end up being the same. And so what is the cohort? What are the real kinds of patients that we see with epilepsy? We could have patients like this, which has a small tumor in a part of their brain called the insula. Here's a patient with a cavernous malformation. Here's a patient with hippocampal sclerosis. The scar is seen as this bright white signal. And here's a patient with cortical dysplasia. And you can see all of these abnormalities are highlighted here with these red circles. So there's a wide variety of disorders that all end up being seen in our clinics as patients with intractable or medically refractory epilepsy. And the commonest of these, of course, is temporal lobe epilepsy, which is scarring in the hippocampus, which causes very often intractable epilepsy. This is seen as increased signal on this sequence, a blurring of the hippocampus on this T2 weighted image, and then a PET scan that shows decreased metabolism. The hippocampus is a Greek word for the seahorse. As you can see, the seahorse looks like this, and it doesn't take too much imagination for people to realize that our hippocampus looks similar. And that is often our target. We will keep revisiting the hippocampus in future slides. It has various regions, and it lies on the MRI scan close to the brainstem. So it's deep. It's an important structure for memory. But in the patients we see that have intractable epilepsy, it's not really making memory. It's mostly just making seizures. So when patients get referred to us, they go through this stepwise process of evaluation. And this stepwise process depends vastly on the kind of epilepsy that they have and how clear the problem is. Everyone undergoes a video EEG and imaging studies in the EMU. And then if it looks clear that this patient may well be a surgical candidate, we do something that we just amongst ourselves call a phase 1.5, which is neuropsychological testing, functional mapping with either a MEG, a functional MRI, or a WADA test. And then a subset of these patients will need electrodes implanted inside the brain to pinpoint seizure foci better. That's called a phase 2. And the phase 3 refers to the resection process. It's important for all of us to remember when you go see a neurologist and they order one test after another, people can often be puzzled, why is all this going on? And really what we're trying to do is to outline the seizure network with a variety of these tests. And the tests might vary, but these tests taken together then define the problem in best detail. It's very clear from multiple papers now that have come out in the literature that epilepsy surgery is exceedingly effective. So in Canada, as many of you know, they have a socialized healthcare system, so there's a problem with access to surgeons, and it takes a while for patients to get to the point of getting epilepsy surgery, even when they have been determined to be the right patient to have it and they're willing to have it. And so it allowed this center in London, Ontario to randomize, to break people down into two groups of patients, of 40 groups each. One that they put off for 1 year because that is what their scheduled waiting period would normally be to have the surgery. And then the other half they used funding from the government to get them surgery faster. And at the end of 1 year, they showed that only 8% of the medical group was seizure-free and 58% of the surgery group was seizure-free. This paper is very old, it's from 2001. This is before MRI scans were really mainstream. So you can imagine that these numbers don't necessarily reflect what we see today. We see much better numbers than 58% at 1 year. But the point was, it's an exceedingly stark difference, even 20 years ago or 17 years ago, in between epilepsy surgery and medications for epilepsy. Additionally, there was another trial that started out in this country, sponsored by the National Institutes of Health, that looked at whether or not early surgery would be better than waiting to have surgery. So this was patients with hippocampal sclerosis or damage or scarring of the hippocampus who were diagnosed with mesial temporal lobe epilepsy. And the question was, should they wait to fail multiple medications or should they have surgery? And this trial did not complete enrollment of all the patients, but the few patients that they enrolled, there was a very clear difference, even in the small group, that there was a stark difference between medical management and surgical outcome. I put this a different way. Many of you might have friends or know people who've had surgery or stents in their carotid artery. Others might have friends who've had a heart bypass operation. And the numbers needed to treat, this is a standard phrase we use in determining the efficacy of a surgical procedure. The number needed to treat for a carotid operation is 45 to prevent one stroke. So you must operate on 45 patients for one patient to not have a stroke. For a heart bypass, you must operate on 25 to prevent one person from dying of a heart attack. You only have to do 2 temporal lobectomies to make a meaningful difference on the quality of life of people. So there is absolutely no comparison between the efficacy of epilepsy surgery and other kinds of surgeries that are done. Additionally, epilepsy is a burdensome disease. Many of you notice this when you go pick up your medications every month. There is a significant copay that especially is present in patients who are on newer drugs and on multiple drugs, 4 or 5 drugs, and it's an amazing amount of money that gets spent on those drugs. And this is just data from a large number of papers that shows that the average cost, and this is also from relatively recent 2015, the average cost of all epilepsy somewhere is around $8,000 to $10,000 probably per patient per year. Now this is direct cost of drugs and hospitalization and blood tests. It is not the cost of them not working. It is not the cost of someone else taking a day off of work to take care of them. It is not the other social costs of people having to be around and available to help this individual. But the numbers are even bigger when it's intractable epilepsy. So we said these are the numbers for epilepsy, all comers. But if you have intractable epilepsy where you're on multiple medications and you're often having grand mal seizures, falling, ending up in the ER, etc., those costs are much greater and probably between $14,000 and $20,000 a year. So in addition to epilepsy surgery being effective, epilepsy surgery is socio-economically beneficial. So as a society, we step back and say, we have, ultimately any society has only so much money they can spend on healthcare. We are much better served by advocating for epilepsy surgery and having patients undergo this sooner rather than later. And at about 10 years, the costs of epilepsy surgery, you might imagine you have to go to the hospital, have all of these tests done, that must cost money. But guess what? By 10 years, it's cheaper to have had epilepsy surgery than to continue on medication. So why, after all this, why do we not have more patients considering surgery as an option? And I'm sorry if this seems a little self-serving. That is not my intent. My intent is purely to educate people, because I see patients all day, every day, who come to me and ask me, why haven't we been told about this sooner? Why have we seen doctors for the last 2 decades and lost all our ability to do various things in lives, scholastic performance, being able to go to college, being able to be married, be independent, have children? All of that has been taken away from me because of my epilepsy, and why didn't someone tell me this sooner? So I think there's a variety of reasons for this. There are issues of patients being seen in communities where they're not referred to tertiary and level 4 epilepsy programs. And there's a variety of reasons for that. It could be distance, it could be the lack of a relationship between the primary providers and our centers. There are also other provider issues. Even when patients get referred to an epilepsy center, oftentimes these centers are in universities, in academic organizations, where physicians are not necessarily incentivized for performance. They're incentivized to be writing papers and getting grants from the NIH. They're not necessarily incentivized to be seeing 40 new patients a week. So there's oftentimes waiting lists around that. And then for the longest time, I think our community has been so pharmacologically oriented that the awareness of epilepsy surgery in those epileptologists, even in academic centers, is low. There's also a lack of people like me who are fellowship trained in epilepsy surgery, and neurologists who are fellowship trained in epilepsy in a surgical program, so surgically minded epileptologists. And then there are these pragmatic things, and why there aren't more people like me. If neurosurgeons did more spine surgery, they tend to make a lot more, and it's much easier lifestyle. And so there are those sort of pragmatic reasons. And so in many ways, for many of us, this is a labor of love. And it is important to do this, not just to further the field and to make these numbers look better, but really for the quality of life and changing what people are able to do once they become seizure free. There's almost nothing more gratifying for any of us than to see somebody back 6 months, 3 months out after epilepsy surgery, who is now driving, is independent, and is ecstatic that their life has been given back to them. And there's very few things in medicine, in all of medicine, I would say, where we can do that reliably. There are, of course, also patient issues, and I think this is a important reason why these sorts of venues are important. Patients are scared of having surgery. So we and other centers, I think, have created support groups where patients can connect with other patients who've had epilepsy surgery and hear from them and understand what was their experience like. Because doctors are going to have a way of expressing things, and I think it helps for patients to hear that from other patients. And then, of course, this concern of all of my brain is important, and how can you cut something out? And no one doubts that. In my spare time, and I have a lot of spare time, I study cognition and language. And so, to me, also, all brain is important. But this is a decision-making of risk versus benefit. I think Tom Melody pointed this out earlier. Would you rather have a part of the brain that mostly makes seizures and occasionally is used for something helpful, or not have it at all, and then not have the epilepsy? So, with this, I'm going to start jumping into a few cases. I'm going to go through these very quickly. It's just a proof of concept, an idea of what the various components of these types of epilepsy really look like and what the manifestations are. This is a young lady who I saw when she was then 22. This was about 4 months after I first moved to Houston. And she'd had seizures since she was 15. She'd had multiple evaluations, and she had clear scarring in the right hippocampus, as you can see there. This is, and I'm sorry, there'll be some surgical specimens and surgical pictures in here. I apologize for doing this after lunch. If anyone is squeamish, please close your eyes briefly. The pictures will pass. But there is no active bleeding in any of them, okay? So these are the typical specimens that we remove after a temporal lobe resection: the temporal pole, the hippocampus, and the amygdala. This is her now. She's now 12 years out from surgery. She's had no seizures. Her then boyfriend proposed to her in the recovery room, and they got married. She sent me this picture of her wedding gown, and she now has 3 kids and is, as you might imagine, has no time for me or anybody else. And this is a different story. This is a 63-year-old rancher with a 6-month episode of tingling and numbness in his left arm. He happened to be the father of one of our rehab physicians. These were going on for a while. He went and saw his cardiologist. They thought he was having some kind of angina. They put a stent in his heart, but these episodes kept getting worse, and then he had a grand mal seizure, which prompted him to have this MRI scan. So here we can see a large abnormality in the right temporal lobe, in the right insula, a very large mass in the brain. And this is a tumor within the brain substance, a glioma, and this is why this particular gentleman was having these kinds of seizures that originate in the insula and in the hippocampus. And these structures are a little hard to resect when they are involved with extensive tumors, but it can be done. And certainly many of us have expertise in this. And here's his MRI scan afterwards, and as you can see, that's this fluid in the brain where the tumor used to be, and the mass has been completely dissected. So he was seizure-free for 3 years. Unfortunately, after that time, his tumor came back, and a few years ago, just maybe about 2 years ago, he succumbed to his tumor, which was now a cancerous growth. But he had a 6-year survival with this process and no seizures for that period of time. So obviously, this is a very different disease from the kinds of epilepsy that most of us talk about, but it still is in epilepsy, and it's often under-recognized. Here's another interesting patient. I saw him also many years ago, a 19-year-old with history of neurofibromatosis. This is a condition where you have little growths on your skin. You might have seen people with lots of little bumps coming off of their skin. And this particular young man started having staring spells and then having some bigger seizures than that as well, some grand mal seizures about once a month. And in addition, he developed this urge to go and urinate every 20 minutes, which made him not able to sleep and was exceedingly disruptive to his family. So he had this abnormality in his brain, very clear abnormality, which you can see here as on a PET scan. This is hypermetabolic or has increased metabolism, and this was then removed at surgery. Was turned out to be an area of dysplasia, and he underwent a complete and successful resection of this and has been seizure free. We did this one as part of an awake operation, with the patient awake. So oftentimes when there is language or movement around important brain areas, we need to preserve those functions and yet remove this abnormality. So I do an awake operation at least every other week or so, either for a brain tumor or for somebody with epilepsy. So this is him afterwards, and this was 4 months. This MRI scan was 4 months post-op. He's now quite many years out and still seizure-free. So getting back to this idea of localization of the epileptic network, there are various components. There's an MRI scan that's often necessary, the behavior during a seizure, the MEG, which is a device, a machine that picks up very subtle brain abnormalities and brain waves, nuclear medicine scans like you've seen, PET scans, neuropsychological testing. Dr. Dooley was here earlier, and that's what Dr. Dooley does. He assesses whether the epilepsy has had an impact on your memory or on your language. And we're going to focus a little bit on the intracranial evaluations for a little while and talk about what that looks like. So this was another young lady who had epilepsy since infancy, and as you can see, there's a laundry list of medications that she had failed. She had a vagus nerve also implanted elsewhere, and she also had left mesial temporal sclerosis, but her EEG was not very well localized. So this is the old way that we used to evaluate these epilepsies. We'd do a craniotomy and place a grid of electrodes on the surface of the brain, and that looks like this. It's a big operation, and the sheet of electrodes is placed on the brain surface. We then do mapping in the epilepsy monitoring unit with these electrodes in place. We end up with something that looks like this, which is a map of all the electrodes on the various brain regions. The black little spots are the areas where language is present. We mark out those areas separate from the areas where the seizures are coming from. And then we use this sort of three-dimensional image in surgery when the patient comes back to plan then a resection of the areas that are causing the epilepsy. In this case, a part of the temporal lobe and a small part of the frontal lobe was resected. And she has done exceedingly well. She is now about 9 years out and is seizure-free as well. So the decisions for resections in surgery depend on a variety of things. We need to know where the seizures are coming from. We need to know what is important. We need to know what the impact of what we propose to do on those brain functions is going to look like. And as time has gone on, our understanding of brain function has gotten a lot more sophisticated. 20, 30 years ago, we were happy if patients just walked out of the hospital. But now we want them to be able to tweet, and we want them to be able to send us emails 2 days later and upload pictures on Facebook. So our goals keep changing and getting hopefully more in line with higher function. And in keeping with that, we now have different new techniques that we use, and the rest of the talk is going to be about really talking about this. So in addition to, we've talked about the high resolution MRI scans, MEG, PET scans, fMRI, DTI. We also do stereo EEG. We were the first center in Texas, the second in America, to have a stereo EEG program, and we were one of the pioneers also in laser ablation in the nation. I think we were the 4th or 5th site for laser ablation. So we'll take a step back first before we go into those and talk a little bit about imaging, because oftentimes patients have been seen at various centers and have been told there's nothing wrong with you on your MRI scan. We therefore cannot tell you where your seizures are coming from. And it's usually, not usually, it's oftentimes a consequence of A, people either not knowing what to look for, or B, the scans not being of good enough quality. And here's an example of a patient in our own center when I first started who had seizures. And I'm just going to jump to show you the comparison of these two types of slides. This is the 1.5 Tesla MRI scan. Most patients in the community get a 1.5 Tesla MRI scan, which really doesn't show much abnormality at all. And then this is a 3 Tesla MRI scan, and you can see the difference in detail is stark. And it tells us much more about what is going on. In this case, you can see an abnormality right next to the hippocampus. This is called a periventricular nodular heterotopia. It's a fancy name for an abnormality of brain formation that you can see on multiple slices that's barely visible, even in retrospect, on the original MRI scan. And so this patient would not have been benefited if we hadn't looked closely and gotten better scans. Additionally, we've had a very vast experience with a different type of disease. Here is another patient with an MRI scan that looks essentially normal. Then they get a better scan, and then you see there's a little outpouching of the brain in the temporal lobe, a little abnormality, a little bubble there. And this is something we call a temporal lobe encephalocele. This comes in various locations. This is another case with a small bubble of brain and spinal fluid. Here's another one. And they can come in various sizes. Here's a very large one. No one would miss this one, but these subtle ones can be missed. And these patients are often underdiagnosed, and at this point about 7% of our patients that we see with temporal lobe epilepsy have meningoencephaloceles. This slide is a bit dated. We now have about 42 patients with meningoencephaloceles, of which something like 27 have had surgery. So it's the world's largest series on encephaloceles that hopefully we will get out in the literature soon as well. And here's one of our patients who was recently in the news, James and Jimmy Burke. James is the patient in the middle. This is him running the Houston half marathon or marathon after surgery for an encephalocele that he was seen at multiple epilepsy programs around the nation, and this was missed. Because again, you have to look closely, and you have to know sort of what you're looking for. So another way of expressing that is out of sight, out of mind, or out of mind, out of sight. And you need to have standard protocols. We also feel at some point in the future having an even higher strength MRI scanner, a 7 Tesla MRI scan, might help us diagnose epilepsy, very subtle areas of abnormality in the future. Getting back to my favorite slide here, which keeps surfacing, I'm going to talk a little bit about intracranial EEG. So I showed you how electrodes are placed on the brain surface, and they seem to do a very comprehensive job of recording, but you have to remember that 2/3 of all of the brain is actually living inside a groove. So if you blow up this brain or inflate it by pumping air into it in an imaginary sense, of course, you realize that these electrodes that look like they were on the brain surface are actually quite far apart from each other. In addition to the fact that there are these unsampled deep areas, stereoelectroencephalography or SEEG has much lower complication rates. In my personal experience now, we've done 150 patients. We just did a patient of 150 last week. We've had 0 hemorrhages and 0 infections. And so it's hard to match that with any other method of localization of seizures. I still think it's invasive because obviously there is still a procedure done, and I can never say that there's never going to be a risk. But the other big consequence is we often have to shave a lot of hair. And we've tried to limit the haircuts in some cases, but it's still it's difficult for patients to accept that on occasion. And especially for women, that tends to be a problem. They don't want their hair shaved. So that is still invasive. We use these very thin electrodes. They're less than 1 millimeter in diameter. And this is just a video of how this goes. I'll try to play this quickly. This is also on YouTube, so you all can see it. And it's a very meticulous procedure in terms of its planning, and then when we actually get down to executing it, it's done very rapidly, where we identify where we're going to go. We will now drill a small hole in the skull.
Did you guys do this live on YouTube? Wasn't there something done or not?
I I have had surgeries done live, carried on the internet, but I don't think this one was one of them. Yeah, there is. This was made by. This video was shot by the one of the companies that makes the electrodes, so I think they put it out there at some point. But it doesn't matter what electrode you use or whether you use them; the procedure is the same. The robot really helps us. There's more than one robot that does this now, but it's a pretty easy process once you've gotten used to it. And as I said, we were one of the pioneers in this, but at this point there are, I think, about 60 centers around the nation that do stereo EEG. So we're going to measure the length of that little driver and then use that to come up with the length of the electrode that needs to be placed. So this arm of the robot is going to be moved out of the way, and we're going to zoom in on the actual bolt. The bolt is the little piece of metal that goes into the skull through which the electrode goes into the patient's brain. So there's a little stylet that makes the path for the electrode to go through, because the electrode itself is very, very flexible, and it's not rigid enough to make a path for itself. And then there is the actual electrode that's going to go in, and you can see the little contacts on it. I think that projects okay. Yeah, there it goes. And then a little cap that tightens on it. And that, these electrodes often go in as deep as 10, 11 centimeters inside the brain. And so it has to be, the planning has to be meticulous. The registration of the robot to the patient's head has to be meticulous. And once you've done that, the placement is easy. And this is what this looks like after we have placed multiple electrodes. We can then record from different brain areas. We can represent these electrodes. You've seen the one that's on the surface, the grid electrodes, and these are the electrodes that are now inside the brain. We can make various sorts of models of this and representations, and then we can also then represent the actual brain activity on the surface of the brain. So with that in mind, let's talk about a few different kind of patients. So this was a very charming young lady, 26-year-old, very high functioning, had high IQ, had failed 6 medications, had a EEG that looked like a very generalized EEG, had seen neurologists at 4 other centers before she came to us. Everyone had told her she had a primary generalized epilepsy and was not a candidate for epilepsy surgery. But if you looked closely at her EEG, while it started off in a generalized fashion, it always had a right-sided maximum propagation. Her PET was unhelpful. Her MEG, though, was very helpful. It also implicated a focus on the right frontal lobe, just like that delayed seizure recording. And so this is her skull X-ray with these electrodes in place. And as you can tell, many of these probes go deep. It almost looks like a nail gun went off next to her head. And the point of these electrodes is to probe exactly where these seizures are coming from. After we have the electrodes in place, we record where the seizures are coming from, and that's that little area. And this is her brain back at surgery. And as you can see, there's no evidence really where these tiny electrodes have left any damage on the brain. The brain looks really unchanged, although you can see the small holes in the skull where the electrodes went in. And that's then the resection of this part of the brain. She is now slightly over 3 years out from surgery and is seizure-free and is doing great. And of course, her brain tissue that was removed is abnormal. It shows that this part of the brain didn't form correctly. It's laminated or has improper layers, and the brain cells are not lined correctly with each other. This is a different stain showing the same thing. I'm going to skip through this one, even though it's a very compelling case, just in the interest of time. And so this is sort of the old way we used to do evaluations, and then this is the new way. And really, from a patient experience perspective, I don't think there's any comparison in what they can expect, and their pain tolerance and all of that. So what about combining these two? What about combining stereo EEG with a less invasive approach to curing epilepsy? So if we can localize seizures with tiny holes made in the head, can we also cure it with tiny holes made in the head? And you've heard a little bit about this already today, but I want to show you a couple of cases where we actually combined the two things together in the same person. This is a 32-year-old lady whose seizure started when she was 22 years of age. She has a aura of a heat sensation, and then things are spinning around her, and then she has a complex partial seizure. And this is her imaging shows abnormalities in brain formation. These are the names for them: the periventricular heterotopia and the polymicrogyria. This is her IQ. So this is her video recording of a seizure. I don't know if we have audio or not. Maybe we do. So as you can see,
Come with 2 fingers. Can you tell me your name? You're staring. Can you tell me your name? Hold both arms up for me. Can you hold both arms up? You're staring in a swallowing motion. What is this?
this is a very classical complex partial seizure where someone loses awareness, is unable to speak.
Put your arms up for me. Both arms. Humming. Can you tell me your name?
Okay, so I'm going to jump through that. And she had these abnormal spike discharges, had a right temporal seizure onset pattern that's best seen here and here. And then this is her imaging study. The lights don't allow us to see this very well, but she has abnormalities all around this region in the right temporal lobe. And she was also, this is very close to the part of the brain that also is responsible for visual function. And so she is a graphics designer, and we implanted her with electrodes to pinpoint where the seizures are coming from. And if at all, she wants to be able to drive and continue doing her work. And so in this case, knowing where the seizures are coming from, we use laser ablation. The way laser ablation works is we turn on, we put a probe inside the brain, and we turn that probe on and measure the temperatures in real time. And there's a sort of a time-dependent damage that occurs between 45 and 60 degrees centigrade, and that's where we kind of want it. We don't want to go too high where water is going to boil. And at that temperature, that area that's making seizures gets liquefied and destroyed. And here's a sort of a representation of this technique. This technology was actually created here in Texas by 2 postdocs at Texas A&M. And they made a small startup, and then years later it became a mainstream product. So we should all be proud as Texans, the innovation and the biotech startups in Houston. And now, of course, it's a internationally used technique. And as opposed to traditional ways of coagulation of tissue, it makes a very neat and tidy scar, tidy zone of damage around it. This is just a piece of meat that's been either damaged the old way or with using lasers. And so in her case, we put in 2 separate probes to get to these areas. And you can see this is the kind of image that we produce in the MRI scanner of the ablation. First in one probe and then in the other. And we slide the probe in and out depending on which zone we want to really target the best. And then that ends up creating, in this case, the areas outlined in white are the contrasted areas that show the area of ablation. And so all of the tissue that was making the seizures has been targeted and has been destroyed. Now, how did we do? Well, she did lose a little bit of peripheral vision. Black here reflects an area where she doesn't see very well anymore. Those black spots are the blind spots. Everybody has those. So that's really the area that got, a little bit worse, but that is not bad enough for her to not drive, not bad enough for her to not do all the things that she would otherwise want to do in her life. So of course we've combined robots and lasers in various ways. I'm sorry this doesn't project very well. And go to one other case. So this is a really poignant story. 33-year-old NASA engineer whose seizure started at the age of 3. And I saw him years ago, and he refused to have surgery because of concerns of memory decline and dysnomia. And a VNS was placed instead, and the seizures continued. He got married then, he had a son, and then he realized that his wife was not leaving him alone with the son. And he confronted her, and she said, there's no way I'm going to leave the home and leave you alone with my boy in case you have a seizure or you can't take him to the park, and I'm not sure if you should even take him in the stroller. And she was just being protective as a mother. So he came back to see me because his VNS battery had died. And at that point, he was interested in laser ablation. So this was him with his post-ablation images. And that's how we target the hippocampus. You can see this is all the various zones of ablation in this case. And this is him now. And you can see here's his IQ. Really, the only change was that he got better. This doesn't happen all the time, and patients always come to me and say, well, if this is bad and you're going to take it out, I'm going to get better afterwards, right? I said, no, well, occasionally it happens, but don't count on that. And he's still working on discharging plasma from the International Space Station. Turns out the space station gets charged by cosmic radiations. And if you send anything from Earth, it has a different charge compared to the space station. You have to make those two charges match up, otherwise there'll be a spark between them, and that could damage things. And so that's what he does. Not something simple. So this is sort of where our center has been with SEEG and subdural grids. As you can see, this is the grids that we used to do, and the numbers are plateauing, and the number of SEEGs have been going up at the same time. It's important to remember that patients who need intracranial evaluations are not likely to do as well as patients who don't need intracranial evaluations, because those are patients in whom the seizures are automatically well characterized by the image itself. So there is always a lower probability of success for those who have SEEG done compared to those who didn't even need it in the first place. And so overall, about 60% patients do well, either seizure-free or markedly benefited. This is at about 2 years out, so it's pretty good follow-up. But also, 25% don't have surgery after SEEG, or they don't have resection. They have something else, and we'll talk about something else in a little bit. Either they have VNS, or they have a neuropace, or RNS, or we try different medications on them. And on the other hand, with visual ACE for epilepsy, this is 68 patients. We just compiled this, and it's in review at this point. The outcomes are really excellent. Seizure freedom and or seizures with auras is at about 2 years is 75%. So that's better than most series of temporal lobe operations anywhere. So a little bit about RNS. RNS came around from this empirical observation that if you had someone in the EMU having a seizure, if you passed a small current into the electrodes that were making the seizures might stop. This led to trials. The FDA approved this device, and this device is a small computer that lives in the skull. We remove a small part of the skull, implant this little device that has a connection to electrodes that are placed where the seizures are coming from. It records the seizures, and then it delivers stimulation to stop the seizures. And this was the original data from the company, and as you can see, this was the patient group that had the device implanted but wasn't turned on initially, and this is the group that had the device turned on. So there's a big difference there. Again, most of these patients are not seizure free. This is seizure reduction. The goal of RNS and VNS is not necessarily to make people seizure free, and therefore it is, in our minds and the minds of most other centers, reserved for patients that either have too high a risk of deficit from an operation that might make them seizure free, or are just not a candidate for any kind of resective surgery. This is an X-ray of what the device and the electrodes looks like in a patient. This is what we're doing in my lab. We're trying to come up with much more innovative ways of creating neurostimulation, understanding networks of individual patient epilepsies, both from imaging as well as from intracranial devices. We hope that this will give us better technologies in the years ahead to help patients. And ultimately, all these minimally invasive techniques might also set us up in the future for therapies that are also minimally invasive, like a drug that can be delivered into a tiny little spot of the brain, doesn't affect the whole brain, but it's delivered only to the spot that makes the epilepsy, or a mechanism for cooling that part of the brain, because we know cooling really has a huge impact on preventing seizures. You can't cool your body enough to stop seizures, so don't try that. But we're talking about cooling a very small part of your brain. Many neurologists and neuropsychologists at our institution have helped me along the way, and I appreciate all of their contributions. And then all of these young men and women in my lab who have had the privilege of working with on various research projects, and who help make all the pretty pictures in the lab. So thank you all for your time, and if there's any questions, I'm happy to take them. Happy to answer anything else. Sure.
So you mentioned some of these cases are being overlooked, and so you're a surgeon, right? Okay, so typically you go to the neurologist. Are the neurologists able to identify? So how do you get your hands on a case?
Yeah, it's a very interesting story. So for many years, I was the way this worked solely was from neurologists sending me patients, and typically it was only my neurologists at UT Health that I worked with. As time has gone on, community neurologists became more aware of what we were doing, and we have a large Mission Neuroscience Institute that has neurologists in the community, and many of them are sources of patients to us as well, after they've sort of gotten exposed to the fact that this is what we do. And then there's no better advocate than their own former patient going back to them in their office and telling them, hey, look at me, remember me? I don't have seizures anymore. I just wanted to come by and say hello, or, thanks for sending me to Dr. So-and-so, whatever. And then increasingly over the last maybe 2 or 3 years, I've had a interesting turnaround. I don't know how it will go in years in the future, of patients sending me patients. And that's always a mixed bag. Sometimes those patients don't even have epilepsy, but sometimes you have to be a willing ear. Patients just need their story heard, and you can act as a chaperone in the healthcare system, which is complex and daunting, and give them direction of what they actually need. And so it takes some time, but it's not, it's still helpful. But it's really these three sources. So patients who come to the neurologists at our university, patients from community neurologists who get sent to us, and then patients referred to us from other patients.
What about those patients who have had 3 brain surgeries already?
Yeah.
And if still have epilepsy, still have abnormal EEGs.
Yeah.
Are those cases that you still look at?
Absolutely. So I didn't add in here, I should probably make a talk about this, is epilepsy surgery after prior failed epilepsy surgery. There is certainly, I would say there's 2 types of failures. There are patients who maybe are multifocal, have too many different areas of the brain making seizures, who perhaps are not even the best candidates for epilepsy surgery. The first time it was done in some, as a desperate measure to try to help them. And then there are those in whom maybe the precise area was not localized or was not removed. We're all imperfect, right? And even though I think we all try to do our best, I have failures, and I kick myself for them, but it happens, and we learn from every one of them, and we move on. So I certainly don't think that having had epilepsy surgery precludes you from having epilepsy surgery. Another aspect of failed epilepsy surgery that we didn't have an option for before is RNS. So if we know exactly where seizures are coming from, but that area cannot be removed, and 2 prior operations, say for example, have tried to get to the point but have stopped just short of something important in the brain that cannot be removed, that may be a perfect candidate for RNS.
I have a question online. Is there a higher reduction of seizures when using VNS or RNS?
It's a great question. If you look at the data that were used for getting FDA approval for these 2 devices, so now those data are the data that are the most controlled data. They were collected with patients not knowing whether they were getting stimulated, and they were collected with the doctors in many cases not knowing, where the patient was in the process of getting stimulated. The results are roughly equivalent. So it's about half, give or take, half the patients have about half 50% reduction in seizure frequency. Now, it's always a little difficult to know what happens later, and is that are the patients who have followed longer because their device was helpful in the first place. In other words, the ones whose devices were not helpful, had them removed, had them turned off, didn't come back to see you, right? When you're doing an FDA study, everyone counts. You can't lose those patients. So you have to follow them and you have to report them. But 2 years, 3 years down, likely the patients who keep coming back are the ones who are seeing a benefit. And certainly in that cohort, you see a higher number in both the VNS as well as in the RNS series. There are, I think it's still early. I think more data will come out, but I would put it this way: if someone knows clearly where the seizures are coming from, and there's not any doubt, then I think RNS is probably the better option. And I think if it's not clear where the focus is, then maybe VNS is a better option up front. And again, we have many patients now who have both devices. And it's again important to point out that 15 years ago we had neither of these devices really widely available. And RNS has only been on the market after FDA approval for 2 or 3 years. So, and this is only version 1.0 of that device. So there's a lot of hope in technology, and a lot of hope in new interventions and new ways of even delivering drugs for epilepsy. So if you have a loved one with epilepsy and they're not ready to take the plunge, there's nothing wrong with waiting. But just recognize, of course, that epilepsy is a disease that sort of multiplies on itself. Seizures beget seizures, and the brain is a learning machine, and it learns how to make seizures more and more efficiently as time goes on. So something is often necessary to stop that cycle. And whether it's a new drug, whether it's an intervention, it really depends on what patients prefer. Yes, Martha.
I just wanted to make a comment that we learned recently just from being involved with you is if anyone here is on this journey and has not had an updated scan or MRI, that what Dr. Tandon was saying, that it's the Tesla 3 machine, the newer machines, and getting an updated scan on these particular machines can sometimes show the doctors, or now show the doctors, reveal more than a scan that is on not a epilepsy protocol machine. And so I know for one of his patients that made a difference, and also Dr. Tannen's interpretation of that scan is how he was able to diagnose him.
Absolutely. And so just to amplify further what Martha just said, it's important to get a good scan. It's also important to be seen at an epilepsy program where people know what they're looking for. Because a community neuroradiologist, the person who interprets these scans, doesn't see patients with epilepsy that often. The neuroradiologists at our centers see patients with epilepsy at least 10 times a week. And in fact, in our center, there's only one person who sees all the scans. So, you subspecialize to that individual, so nothing gets missed. And so there are 3 level 4 centers in Houston. Certainly, we would love to see you. If you don't like coming to UT or Memorial Hermann, then there are 2 others. But that is the place where I think all significant intractable epilepsies should at least be evaluated. Well, thank you all. You've been a great audience. I'll be around for a little bit. We can chat some more. Thank you.
All right. Thank you, Dr. Tandon.